I'm Gloria Campos, and I'm here again with Dr. Bill Johnson and Innovations Medical, and we're talking about stem cell deployment. And now we're actually going to walk through this procedure and who actually should be interested in this, Dr.
Yeah,
Johnson.
help patients know what to expect. This is kind of a new world for a lot of people.
And both of your patients told me that one of them saw you on television and heard you talking about it. The other one did some research after a relative came and had a successful treatment. So tell me a little bit, for one thing, let's start at the beginning. What kind of disorders are you seeing and treating with this stem cell therapy, could I call it?
Stem cell therapy. The area that we have the very most data, the area we feel the very most confidence is in arthritis disorders. Knees, hips, shoulders, elbows, wrists. We're doing very well, and evidence is really increasing. We're learning more and more who's not a good candidate. And so the majority of the time we're seeing really nice responses. We're doing more and more COPD patients. Some of the COPD websites are starting to recommend this as an alternative. We're learning more and more. We've had some folks with a really dramatic response, others with less dramatic response. But what's really unique in the COPD world is, having treated for many years as an internist, there's nothing you can offer those folks to reverse their illness. And this is the first time something has been around with the potential of actually reversing their illness. We're doing a lot of work with neurologic disorders. Probably have the most experience with neuropathies because we can deploy the cells not only IV, but we can also deploy the cells locally into the area that they have a problem. And so we're seeing really nice responses in those folks. We're doing stroke patients, MS patients, ALS patients, seeing some response in those and getting better at it, I think, all the time. We're doing some neurologic disorders like male erectile dysfunction, Peyronie's disease, interstitial cystitis. We're doing some work with patients with heart failure. That was one of my personal interests, one of the reasons I got involved in this to begin with. And again, seeing some folks that have some increased mobility, increased ability to breathe and move around from their heart failure.
Now we know that stem cells have the ability, the capability of regenerating and just making duplicates of themselves. You're harvesting these stem cells from a person's fat,
Yes.
Which is basically through liposuction, which is a very common procedure. What is the difference between the stem cells that you're harvesting from the fat than, say, embryonic stem cells?
Well, these are called adult stem cells because they come from an adult. They're your stem cells because we're getting them from your fat. Embryonic cells are cells that have been taken from typically a frozen embryo, an embryo that has been derived from an in vitro fertilization. And typically when they do that, they will harvest a large number of eggs and fertilize anywhere from 10 to 12.
Mm-hmm.
And rarely does anyone use all 10 or 12. And so there's an estimated 35 to 40,000 fetuses in the United States that are frozen right now because they are in existence and mom and dad don't want to raise that many more children. And so some of those have been historically used in small amounts because very tightly controlled in the United States.
Mm-hmm.
Some of those have been used for stem cells for other individuals. That has a lot of legal and ethical ramifications, and while there is some good work being done, it's probably never going to be widespread because there are concerns about ever having a baby just to benefit yourself.
Right.
There's also cord blood being used,
Mm-hmm.
and cord blood has started becoming mentioned as a non-living, non-related. And the issue with that is cord blood has only stem cells in small numbers,
Mm-hmm.
but also there is a slight risk of what's called graft versus host disease,
Right.
where when you receive stem cells from a non-related donor, then those stem cells can come in and attack the person that receives them. And so there's some concerns on that with cord blood.
Cord blood, there's the possibility of
Graft versus host.
graft versus host which is basically like where the tissue would attack,
Where
because
the-
it's not from
where
you.
the donated tissue
Right.
attacks the new host.
Right,
So it's a different disorder from the host body rejecting a transplanted organ. It's the opposite. It's the transplanted organ rejecting the host.
wow.
Okay.
So then there's also, obviously, we hear a lot about bone marrow
Well,
transplants.
and bone marrow are also known as hematopoietic stem cells because they come from hemato or blood origin.
Okay,
They are the leader in the United States and they've been around the United States for 30 years. And everyone you've ever heard that had a bone marrow transplant, that was really a stem cell transplant. And now they've been referred to as hematopoietic stem cell transplant as opposed to bone marrow transplant. Because it's only the stem cells that are able of producing new blood cells in the recipient. The issue with hematopoietic is it gets many fewer cells from a harvest. So in order to have enough cells to transfer, you have to grow them out in blades. And that requires a bunch of regulatory things from the FDA and really a commercial grade laboratory to be able to do that. So it really adds to the expense of the procedure. The other thing that is important about hematopoietic stem cells versus fat stem cells, as we age, we have fewer and fewer stem cells in our bone marrow, but as we age, fat stem cells stay pretty constant. So by the time we're in our 40s and up, you have to have quite a few pokes, if you would, of the bone marrow to get enough, for quite a few hours to get enough peripheral blood cells, and then you have to plate them out and grow them. Where with fat, we can do it in one procedure in a couple of hours, harvest 50 cc's, which is about 3 tablespoons, and get anywhere from 50 to 100 million stem cells in one setting.
so the stem cells found in one's fat, your fat, my fat, are really the best candidates for helping someone.
They're the most
Regenerate.
readily available and easiest to get, easiest to use.
Okay, so now we're getting people interested in what you've mentioned as far as what you're seeing results in. They've seen the videos. Where do they start?
Well, I think finishing this video is a really good start because they can understand the whole process. But once they feel like, yeah, I'm interested, they can call and meet with a consultant. The consultants are well versed, and if they wish to, they can set an appointment and meet with me. And we can talk about their disorder and make sure that they're a good candidate. Oftentimes, when they meet with the consultant will get the necessary information for me to be able to review the chart, and I can look over their material and let them know if you're a good candidate. We have a lot of patients that come from out of town and even out of state, and so it can be real helpful to know before you get in and drive or fly here that, yeah, this is going to be a good idea for me when it's done.
Right, so there is a procedure then. So you've looked at what are you looking for in their materials?
We're looking to see, is this a good candidate? Are they a good joint candidate? Are they a good lung candidate? Do they have a profile for one of the disorders that we know we're having some effect, and that we have an IRB protocol? One of the things that's real important to know is we're working under the guidance of an investigational review board,
Okay,
an IRB.
okay,
The IRB looks at all the things we're doing and says, yes, that's safe for doing in human beings, and they give us blessings on how we do what we do. And because of that, we have some protection in the state of Texas, because the state of Texas says you can do stem cells as long as you're working with an IRB. It also gives our patients some assurance that we're not just out to make a buck or just out to take something from them. We're actually doing legitimate research that has oversight by an investigational board, and we are reviewed on a regular basis. We put all of our data into a common data bank, and so when patients come in, what they ultimately have to fit is they have to fit into one of our protocols that the IRB has set out for us.
And approved.
And be approved.
Mhm.
And so we look and say, yeah, we can fit them under our neurologic protocol, or we can fit them under orthopedic protocols, and that way we can say, yeah, you're okay to do this.
Okay, so say they're a good candidate, and you've reviewed their information, what happens next?
Well, now there's a lot of paperwork, okay? And anyone that's had a surgery in a U.S. hospital the last few years knows there's a whole lot of paperwork to be done. And top of that, we have paperwork that has to do with this being investigational. So it'll take an hour for someone that really is going to actually read, which we highly recommend. It'll take an hour for someone to read and go through and sign all the materials. And so for that reason, you can avail yourself of getting it over the web and have a chance to look at it before you even come in.
Yeah.
If you want to do it here in the office, that's fine. But you need to understand, you need to be here about an hour ahead of time. It's going to take you an hour to dutifully do the paperwork, and we really encourage you to do that because
And understand it.
You want the paperwork. Yeah, there are a lot of regulatory reasons for it being there, but ultimately it's there for the patient's protection. Ultimately it's there so the patient really understands what's about to happen. And by signing on that, that's what they're acknowledging, that I understand what's about to happen and why it's about to happen.
And it's patient-driven research. They are part of a research project.
They are part of the research project, and that's also made clear within the paperwork.
Okay, so, all right, so they've done their paperwork. If you recommend doing that before you even step foot
Absolutely.
here. They
It's
can do it
best.
over the internet. Once they get here, the day of the procedure, what happens? You know, a lot of times they tell you, don't take aspirin, don't do this and that. What do you tell them?
We prefer not to have aspirin, but that's something with some of their disorders. We actually will do a harvest with patients on aspirin, and we've done that safely.
Okay.
So if they're on blood thinners or anticoagulants, they need to let us know before they arrive. We can give them instructions on that.
Okay.
We've also found that patients with arthritis, for example, do a little bit better if they've been off their anti-inflammatory medications for a day or two.
Why is that?
It looks like that when we have a little bit of inflammation, let's talk about a knee. Let's say you've got a bad knee and you're on naproxen or an ibuprofen for it. Those drugs are anti-inflammatory. And one of the things they do is they decrease the amount of growth factors in your knee that are yelling for help.
Oh, okay.
So about anywhere from 2 to 3 days beforehand, we like folks to stop those. So we like those growth factors yelling for help. Because when we put our stem cells in the knee and we put our stem cells in the vein, those growth factors call to our stem cells and encourage them to change into the type of cells we need. So that's been one of the newer things we have learned in the past year, that having a little bit of inflammation in joints and nerves and other things helps. And so we like them to stop their drugs a couple of days. They don't have to be in horrible pain. They don't have to be in full-blown rheumatoid arthritis flare. We just need a little bit to get the job we need done.
And everything works better then, it sounds
That's right.
like. Well, like everything, once you've done the paperwork, which you said takes about an hour, and you know what what's going to happen, and we'll talk about that a little bit more. What are the risks? We're doing liposuction to get your fat. It's processed here in the office and then basically injected, say, into your knee, right here, one day. How long at a time?
It takes about 2.5 hours. Okay, from the moment you hit the door till the time you leave. You probably add an hour for that if you haven't done your paperwork. We'll take you first and do a little pre-op exam. Okay, if I haven't met you before, then we'll examine you, make sure that we are safe to do the harvest, do a little blood work to make sure we can do a little minor surgery.
Okay.
And then we take some pictures. And typically we don't medicate. It's too comfortable. So we don't even give a sedative or a pain medicine because it's just not necessary. We'll take you in, we'll do the harvest under a local. And the harvest takes a whole lot less time than we've been talking here. It takes about 5 to 10 minutes to do the harvest.
Wow. And it's from your belly usually?
We can do it anywhere. We do it most often from abdomen because it's easy. It's easy access, and most of us in the United States have some excess fat there. But we can take it from anywhere you have fat, and we've occasionally taken it from a flank or a knee. So there are other areas we can take it if we need to.
So all of this takes about, you said about 3 hours.
Takes about, now, once we have the fat,
Right.
we take it and first we centrifuge it, separate it out from the numbing fluid. Then we add an enzyme called collagenase. And what it does, all of the fat cells are interconnected by strands of collagen, which is a protein.
Right.
The collagenase, all it does is break down that collagen so that now the stem cell and the fat cells and the stem cells are all floating free.
Okay.
So when I spin it again in a centrifuge, the fat cells are lighter than the stem cells.
Okay.
So stem cells all go to the bottom.
Wow.
Then we wash away the collagenase, and at the end we have a product that is properly referred to as stromal vascular fraction, or SVF. From the 50 cc's of those 3 tablespoons of fat, when we're finished, we have 50 to 100 million stem cells and a large amount of growth factors. And these growth factors are highly anti-inflammatory. So a lot of the early benefit we see from deploying this comes from the growth factors turning off inflammation.
Wow. And that's what we probably saw in JD, one of the patients that we interviewed.
And folks that have an early response were convinced that that's predominantly due to the growth factors, because everything tells us it really takes about 3 months for stem cells to recognize where they are, turn into what we need, and grow in enough numbers to produce a change in symptoms.
To heal.
To heal.
Period. Okay, so what are the risks here in this?
The risks are really minimal. You've got all the risk of liposuction. It's a small volume liposuction, so it's possible to be an infection, but we've done nationally probably around 2,000 cases and never had an infection. Given the typical infection rate of liposuction today, it's very likely we'll never see an infection. There's one patient that was done within a network, not one of ours, that was on a blood thinner that couldn't be stopped. They got a little blood clot in the area where they were harvested.
Okay.
We've actually done several patients on blood thinner here and had no problems. So even that is unlikely.
Okay.
So but you do have a problem with some bruising. You usually see a little bruising. You'll see a little swelling. And that's realistically what most people have. Since it's your cells, there's really no chance of reaction. So the risk of taking the stem cells and giving them back to you is quite minimal.
You wouldn't be making yourself sick because it's your
It's
own
you.
tissue.
That's
Right.
correct.
So benefits.
The benefits are what we're investigating. Now, and I think it's important to say that up front and for folks to understand that. That said, these, we're seeing about 85% of patients respond with a resolution of pain. And hips are around 75 to 80%. Shoulders up around 95%. So doing very well. We're doing very well with neuropathic pain. Those patients are doing very well. And many of them are, as they wait, because you often see a real rapid improvement with pain, but over time they're also seeing a return to normal function of the neurons and seeing some of the numbness and deadness go away.
Yeah.
With COPD, seeing patients that, the thing that's been most reliable is seeing patients that were spending 3 or 4 months a year in the hospital, not have to go back in the hospital. That's been the thing we've seen the most. Seen some improvement in exercise tolerance as well, which is what we're really looking for. And erectile dysfunction done very well. Not had to have anyone back. Everyone responded so well with that one. Doing very well with some of the other neurologic disorders. Some of them are, a little bit, you'll take what you can get. Have stroke patient that's have less spasticity and increased flexibility where she had a stroke. Had patients with MS and ALS that have arrested their disease, and with ALS even that can be important because it's progressive disease. And if you're able to stop it, that in itself is significant.
Right. Well, we're talking about, you said we're doing research here. and this isn't covered by insurance. And it is a little expensive, but compared to a knee replacement, tell us a little bit about
Well,
this.
we charge typically $5,000 for a deployment and $2,000 for repeated deployment. The typical knee replacement total charge that everyone experiences, your insurance company, everyone, is typically around $100,000 by the time you finish rehab.
Wow.
Your cost on that is probably going to be more than the $5,000 on your deductibles and copays and that sort of thing. So from a cost standpoint, it is still a very reasonable way, and from a savings on pain and discomfort standpoint, pretty significant improvement.
Right, and really, because the research is kind of preliminary at this point, you don't know that how long it might last. You can't empirically say.
We've got people that are 5 years out still
Okay.
doing well.
Okay.
But we really can't speak much beyond the 5-year window because there's no one out there beyond 5 years.
Wow. Wow. But this is really, really giving people not only hope, but giving their lives back.
Yeah, we've got, on the joint pains, we really can say that. And folks with some of the inflammatory arthropathies, rheumatoid arthritis, and the others, really making a big difference. Some of the other disorders, we're making some difference in areas that you couldn't make any difference before. At all. And so, while it may not be everything we want, we're getting better all the time. And we're talking about disorders that prior to now, you couldn't do anything for.
So you've had the deployment, you've walked through, you harvested the fat, you reduced it down to the stem cells. After the deployment, what can the patient expect?
Well, the majority of patients depend somewhat on their disorder, but the
Okay.
typical knee, for example, most of those patients see a very early response within a day or two. And that tends to get better for 3 to 4 weeks and then plateau. And we believe that's all due to the growth factors. Now, over a few weeks, some of those patients will get worse, but most of our patients have plateaued, and then at about 3 months start seeing an ongoing improvement. And we believe that second slope of improvement is the stem cells finally growing in enough numbers to make a difference.
And when you say growing in enough number, they have basically repaired.
They're starting to do their repairing, and will continue to do that for several months to a year.
Wow. And that's after the deployment of the
That's
stem
after the
cells.
deployment of stem cells.
So I guess you would recommend anyone to check these videos, right, carefully. But you're always readily available to
We're readily
answer
available.
questions.
Alan Wojtek is my assistant. Alan does all these consults. He's always up to date on this and more readily available, and is an excellent source for patients to get questions answered.
And we also have some videos about patients that have undergone the procedures and are very pleased with the
And
results.
they can take a look and see and get some understanding of what this is like.
And they are very happy. I can just
They
say
are.
that for a fact. Thanks a lot for your time,
Oh, thank
Dr.
you.
Johnson. Appreciate it.